Hi, my name is Jonathan Durantano, and I'm an assistant professor of otolaryngology head neck surgery at MedStar Georgetown University Hospital in Washington, D.C. In this video, I will be discussing anterolateral thigh free flap reconstruction. An anterolateral thigh free flap, also known as an ALT free flap, is a flap of tissue consisting of skin, fat, and fascia taken from the lateral aspect of the thigh. This flap of tissue is supplied by branches of an artery called the descending lateral circumflex femoral artery and its associated veins. The artery supplies blood flow to the flap, and the veins drain blood flow away from the flap. The ALT flap is removed from the leg along with its artery and vein, and then transferred to the area of your head and neck which needs reconstruction. The flap artery and vein are connected to a similar size artery and vein in the neck in order to reestablish blood flow within the flap. If your surgery requires removal of the lymph nodes in the neck, then the blood vessels in the neck can be accessed through this existing neck incision. If your surgery does not require lymph node removal, then I will use a small incision, either under your jaw or in front of your ear, to access an artery and vein. Reconnecting the blood vessels requires meticulous technique, as these blood vessels have a diameter of 1 to 2 millimeters, and the sutures used are finer than a human hair. The surgery to reconnect blood vessels is performed under high magnification using a surgical microscope. Depending on the complexity of the defect, total surgical time is usually between 8 to 12 hours. The ALT free flap is a very versatile flap that can be used to reconstruct a variety of head and neck defects. The flap is commonly used to reconstruct the tongue, throat, and swallowing passageway. The ALT flap can also be used to reconstruct areas of missing skin, muscle, or fat in the neck, face, and scalp. For an ALT free flap, no special tests are needed before surgery. Because we do not want excessive bleeding during surgery, we would like for you to stop taking any medications that can cause blood thinning. This includes common blood thinners such as aspirin, Plavix, and Coumadin, as well as non-steroidal anti-inflammatory drugs such as ibuprofen. In general, Tylenol is the only over-the-counter pain reliever that does not cause bleeding problems, so it is safe to use in the week before surgery. Because you will be under general anesthesia, do not eat anything after 12 midnight on the night before surgery. The reason that this is required is that when the anesthesiologist is putting you to sleep, you are momentarily paralyzed while the breathing tube is being placed. If there is any food in your stomach while paralyzed, this can come up from the stomach and potentially spill into your lungs, causing aspiration pneumonia. It is okay to take your regular medications with a small sip of water on the morning of surgery, if so instructed by one of the physicians or nurses, but be sure not to eat breakfast or drink your usual morning cup of coffee. After ALT free flap surgery, most patients spend 7 to 10 days in the hospital. The first 3 days are spent in the intensive care unit. This is not because you are so ill that you need to be in the ICU, but because the flap needs to be constantly monitored by a nurse. Because the biggest risk after free flap surgery is that a blood clot could form within the flap artery or vein, the blood flow to the flap site will be checked every hour by the ICU nurses for the first 3 days after surgery. This is done with an ultrasound probe called a Doppler. Your doctors and nurses will also be checking the color and temperature of the flap to ensure that it is healthy. Sometimes the rounding doctors may prick the flap with a small needle to ensure that the flap is bleeding bright red blood. Rest assured that this does not cause any pain, as the flap does not have sensation. The vast majority of complications with free flaps occurs within the first 72 hours after surgery. As such, once you are more than 3 days out from surgery, as long as you are doing well, you will be transferred from the ICU to a routine surgical floor for the remainder of your stay. Once you are on the floor, the nurses will continue to check your flap using the Doppler, but this will occur every 4 hours rather than every hour. If the free flap involves your mouth or throat, you will usually have a breathing tube in your trachea or windpipe called a trach tube. Because of swelling that is expected after surgery, your airway could possibly be compromised without a trach tube. The trach tube is almost always removed before you go home, and the hole in your windpipe will heal on its own within a few days without any stitches. For the first few days that the trach tube is in place, it can sometimes be difficult to speak normally. This is only temporary, and you can still communicate with your nurses and doctors by writing. The initial trach tube that is placed has a cuff on the end of the tube in case you need to be on the ventilator after surgery. Several days after surgery, we replace the cuffed trach tube with an uncuffed trach. Once the uncuffed trach tube is placed, it is generally much easier to speak. If your surgery affects your mouth or throat, you will be unable to eat by mouth immediately afterwards. To maintain your nutrition and help healing, you will be fed through a tube. This tube, called the nasogastric feeding tube, will be inserted into your nose and into your stomach while you are under anesthesia. Your nasogastric feeding tube will remain in place until you're able to swallow foods and liquids by mouth. However, you cannot be discharged home with the nasogastric feeding tube in place. If you are unable to swallow before going home, occasionally a feeding tube may be placed directly into the stomach. This is called a gastrostomy tube, and it is usually performed by one of our interventional radiologists or gastroenterologists. Gastrostomy tubes are temporary, and when you are able to swallow again, the gastrostomy tube can also be removed. To remove accumulated blood and fluid from the operative sites, drains will be placed under the skin of your neck and sometimes within the free flap donor site. These drains will remain in place until fluid drainage is less than 30 milliliters over 24 hours. The drains will then be removed at the bedside, and the procedure for drain removal causes no significant discomfort. Yes, we generally encourage our patients to get out of the hospital bed and into a chair as soon as the first day after surgery, and within the first several days after surgery, we will have you working with our physical therapists and occupational therapists to get out of bed and ambulate the halls. To help reduce the swelling in your face and neck, we will elevate the head of your bed at a 35-degree angle while you are in the hospital. We may ask that you avoid certain head positions during the first week after surgery, as certain head positions might pinch off blood flow to your free flap accidentally. We generally ask that our patients keep their heads in a straightforward or neutral position throughout the day and night. The donor site on your thigh is closed primarily with sutures beneath the surface of the skin and sealed with a layer of staples on top. On rare occasion, the donor site is too tight to be closed primarily. In this case, a small skin graft may be harvested from your thigh and applied to the exposed leg muscle. In order to remove any excess blood or fluid from the donor site, a vacuum drain is inserted at the time of surgery. This drain remains in place until fluid output is less than 30 milliliters over 24 hours when it is removed at the bedside. The surgical staples are usually left in place for approximately 10 to 14 days, after which they are removed. Once your leg is completely healed, you will have a linear scar running down the length of your thigh. It is expected that you will be sore immediately after surgery, as removal of the flap requires tracing of the blood vessels through one of the large quadriceps muscles in the leg. However, you can start walking on the donor leg starting the day after surgery. The skin over the leg is often numb after surgery, but this usually returns to normal within 6 to 12 months. Most patients report no change in the status of the donor leg after surgery, and I expect that you will be able to walk, run, drive, and otherwise function normally. Like all operations, ALT-free flap surgery contains certain inherent risks, including the risks of bleeding, hematoma, seroma, and infection. With free flap specifically, one of the biggest risks is that a clot may form in one of the blood vessels supplying the flap, which could lead to the flap not receiving blood flow and becoming ischemic, or the flap not being able to drain venous blood away and becoming venous congested. In both of these situations, if the clot is not removed and the blood flow is not restored to the flap within a matter of hours, the flap tissue could be irreversibly damaged and die. If the flap dies, then additional surgery is necessary to remove the flap that is not viable and to perform additional reconstruction using either another free flap or possibly a regional free flap. Thankfully, this type of complication is rare, occurring in less than 10% of cases, but it can prolong hospitalization and recovery times. The ALT donor site generally heals very well and has less risk for complication as opposed to other free flaps. However, there remains the risk that the incision may have poor or delayed healing, decreased sensation over the thigh, or decreased movement within the leg. Yes, as Georgetown is an academic teaching hospital, residents and medical students are typically present for ALT-free flap reconstructions. Residents are physicians who have graduated from medical school, but who are learning the additional skills in the operating room and clinic to become surgeons. While I am always in charge of the operation, complex head and neck surgery requires multiple sets of hands to be performed efficiently and safely. Once the operation is over, the residents serve as our eyes and ears for our patients who are recovering in the intensive care unit and on the floor. One of our residents is in-house and on call 24 hours per day, so they are always on hand to help manage any issues that might arise. I firmly believe that the presence of residents and medical students in the hospital is a benefit to patient care. While you are in the hospital, we will apply a topical emollient such as Aquaphor to your external incision sites twice each day. Once you are home, you may gently wash over the incisions with soap and water. Once you are at home, we will have you also apply Aquaphor to the incision sites twice per day for approximately 1 month after surgery. After the first month of healing, you may then use Mederma for an additional 2 months if you wish to optimize healing. We generally start all of our patients who have undergone free-flap surgery on a baby 81 mg aspirin to help thin the blood and prevent clots from occurring within the flap vessels. You will take the baby aspirin for 1 month after surgery. After 1 month, you can stop taking this medication. If you were taking a blood thinning medication prior to surgery, then we will restart that blood thinning medication after surgery. You will also be provided with a prescription for pain medication to take on an as-needed basis. Please call my office if you develop a fever or have redness or increasing swelling or pain around the incision sites. You should also call if you are having an increase in pain, any swallowing problems, or any breathing problems. You will be seen in my clinic regularly for postoperative visits. After sutural or staple removal, you will be seen in clinic every 1 to 2 weeks until your healing is complete. Once you have completely healed, you will usually continue long-term follow-up with your cancer surgeon. You will then see me, your reconstructive surgeon, on an as-needed basis.